Did I do any of these fundamental mistakes?
Can you remember of a situation in which you could think of I wish I knew then what I know now?
When we just related zirconia to a framework material. And we did beautiful frameworks out of zirconia, very precise, but then we veneered them completely, especially on implant-borne restorations for full arches. This was a very, very...
Today we're diving into a fundamental pillar of implant dentistry, the restoration. And whether you work chairside or with the dental lab, this conversation is for you. Because we're going to discuss the role of titanium bases, the tie bases in today's implant dentistry, and why it's not just a technical option, but a vital element in all the restorative workflow. For this, I have the pleasure to have with me Vincent Fehmer from the University of Geneva. He's a master dental technician and also the editor-in-chief of the International Journal of Aesthetic Dentistry. And he brings this unique dual perspective. One side, the evidence-based formation, and on the other side, the daily work of the dental technician in the dental lab. Vincent Fehmer, what a luxury to have you with us at Straumann ProTalk Clinical.
I don't know if it's a luxury, but it's a true pleasure. So thank you very much for having me.
Oh, we're honored. Trust me, I am particularly honored. I would like to start to begin with, when we talk about titanium bases, and we see out there commonly referred as tie bases, right? In the Straumann Variobase. What is exactly we're talking about in today's workflow? Why is it so meaningful today?
Yeah, I mean, first of all, I have to tell that obviously when you asked me to discuss this topic, I was very pleased because this is a topic that is very close to my heart. First of all, it's close to all the dental technicians out there performing and creating those restorations. But then also with the team with Irena Seiler, Joao Pita, we just did a lot of research around the topic of the tie base or Variobase as you called it. So why is it so important? The bottom line, it unites two worlds. On the one hand side, it enables dental technicians to with their own machinery, 5-axis milling machines, to create dental restorations and connect them with these titanium-based abutment, with the Variobase, and thereby have the implant manufacturer that performed the best possible implant connection, the screw channel, the seating of the screw itself, everything up to the standards that no laboratory would ever be able to produce. So therefore, the Variobase or tie base is exactly the link between the laboratory and the implant.
I like how you phrased it, because the restorative side has for many years been perceived by many dentists as quite cumbersome. There's a lot of push and pull, a lot of components to go through. Yes. And titanium bases, the tie base, in Straumann universe, the Variobase seem to have simplified a lot. Is that really the case?
Absolutely. I mean, for all of you who are slightly older, just as we are, maybe not the latest, youngest generation, you will remember that we had these product catalogs that were like little books. So there was just an abutment for every indication, screw retained, a double screw, or even a triple screw. There was nothing that didn't exist in all angulations, in all rotation, in all heights. And today, the tie base, Variobase, just, in a way, unified all these components and made the workflow so much more efficient and also cost effective. Because in the end, the tie base as a concept on an abutment, and when you put a price tag to everything, in the end, this is also a relevant part of our daily routine. We have to make accessible restorations for our patients. And if you think back on all the UCLA type of gold abutments that we have been using in the past, not only that we had to have the expensive alloy to it, but also those abutments were very expensive. Just the physical abutment was expensive, plus then the gold to it and all the manual labor work that went into it. And today, we have something that combines both worlds and is very price efficient and effective. Maybe it's the better word.
You brought up the UCLA abutment, and this goes hand in hand with my next question, because I was thinking, well, it needs to solve a problem, right? We don't launch things to create more problems. Yes. It needs to solve a problem. And speaking of solving problems, what is exactly a key workflow challenge or a material that this helped you work better with? For example, I see this goes hand in hand with monolithic materials and digital workflows. Is it just for that, or what is it, the challenges and the problems we're solving with TiBases?
I mean, there's, I think, two questions. I mean, there's two questions, so there are also two answers. One big aspect is that for a laboratory, there is a huge increase in efficiency and user friendliness in the terms that it's very easy to just buy a certain range of titanium bases covering certain implant dimensions, on the implant manufacturer that you're working with, and that's it. So you have an easy stockage, as we say. And that allows you to then deliver restorations with a very predictable turnover time. That is one aspect, when it just, is the ease of use and also the integration in the workflow that simplifies the entire process extremely, because you can just reference it. It goes down to the library. You have the perfect piece there. You don't have to wait for anything. Then when it comes to the quality of the final restoration, when we now think back of all the individually made and performed abutments, there was a lot of labor work into it, a lot of manual craftsmanship that went into creating and shaping a telescopic abutment into something individual, creating an individual abutment either by means of digital technologies or by means of, casting to a type of UCLA abutment. And that then went on that you would have to invest those abutments, then go into a heat cycle, then, have the lost wax technique, then pour the gold inside, then you would have miscasts. There was all this kind of user interface that was very challenging and demanding. And then again, devesting it, sandblasting, all these critical interfaces, which is something that you want to keep absolutely pristine. You don't want to touch the internal surface of the implant geometry. But just by default, in order to get it de-invested, you had to sandblast it. Also, the screw head position, you had to sandblast it.
Yeah.
So all of these things are basically not ideal for these geometries, for this kind of final product. So with the TiBase, there is something created for us that allows us to leave these surfaces absolutely pristine as they were developed by the companies. And that makes it such a great device for me.
This is something I was reflecting, because in your experience with the Variobase, you mentioned that you have to, back in the days, right? Two elements I would like to discuss with you quickly. As you mentioned, you have to invest and then cast and sandblast. And as you mentioned, age factor, let's put it that way. There was a belief that restorative schemes should follow a stacking approach. There was a cascade of forces. And today we're going more directly towards implant, direct to implant restoration, right? And in your opinion, what kind of feature or design is embedded in such a component that makes this a trustworthy component to move forward in long-term success?
Yeah, I mean, this is a very, very good question. And I have to tell you, we are now using the TiBase concept, the Variobase concept, since it has been established, since it exists. We're using it even before some other manufacturers. But we don't have the long-term evidence, if especially today, focusing on high-strength zirconia as a restorative material. So we are connecting a very, very strong restorative material with a titanium base abutment that enters the implant. And then obviously the weak part in the middle should be the screw. If something happens, it should happen ideally to the screw. But is that the best solution? Comparing it with the past, where maybe we had, like you explained it perfectly well, a stacking kind of scenario with even a prosthetic screw, that certainly the implant would never be harmed or damaged. So having said all of this, what we could refer to is the research that Irena has been doing for such a long time, looking also into zirconia abutments. And that is, I think, a very great example what could happen if you have, for example, a screw loosening, and then there is a zirconia abutment that would literally be able to harm or damage the interface of the implant, which is the absolute no-go scenario you want to have, because everything can break, but the implant has to stay perfect. So for this reason, now that we are combining titanium with titanium, at least both of the sides are equally strong, which is, I think, a good thing to have. And then, for implant surfaces, you even have the rock solid. So a slightly improved strength of the titanium versus the abutment, which again helps a bit to make sure that if something, has a certain fatigue or whatever happens, it happens on the abutment side and not on the implant. But do we have 20 years long-term outcomes? Unfortunately not.
But today we have good reasons to believe we're in the right track.
Absolutely. Absolutely.
And taking in perspective, I mean, you have with you the work you do at University of Geneva, but you also, together with, because of the journal, you interact with many colleagues out there. And to what percentage you see the world is moving towards time-based, or how is this balance?
This is one of the great pleasures and luxuries to be an editor for such a journal, that you're really constantly exposed to the latest literature, and also working at the university where we also have the journal clubs and where we read a lot or listen to a lot of things. The tie-based concept or the Variobase obviously is related to the implant manufacturer. So what you will see is that for some clinicians, it is the absolute 95% of all their restorations are solved with a tie-based concept. And that is very clear. And then there might be some special indications where maybe a cantilever, maybe something that, still makes them deviate from this path and create an individual abutment, full titanium, whatever they look for. But then for some other manufacturer of implants, the versatility, the flexibility that the tie bases offer, they're just not that large. There's just not such a range of tie bases that fulfill all the requests. So for some of them, the tie base only works for a single implant restoration.
I see.
So then automatically, once you move to multiple unit restorations, you have to deviate from the plan. And then some other manufacturers, they don't offer tie bases at all. Mm-hmm. So I think if the implant manufacturer today offers tie bases, and those tie bases in a, let's say, well-developed state, then the laboratory workflow in particular, digital supported with the libraries, will lead to the clinician transitioning more and more towards the tie base.
I like this. And you phrased it really well with the digitally supported libraries. Now I would like to pick your brain on with a bit of criticism towards the dental community. We should all approach our cases top down. Restorative first, we figure out everything else later, not the other way around. With digital technologies, we have a unique opportunity to really see this, how we will look in the future. Yeah. However, now looking from the dental laboratory reality, is this being reflected, or we can improve on our planning? What I'm trying to say is that, are we still far behind that implants are being placed, not taking proper care of the future restoration? Then they get scanned and you have to figure it out later, or this is already changing too?
Yes. I mean, first of all, I guess every lab technician knows or is to some extent
put you in a corner,
an acrobat, that has to be able to once in a while do a flick-flack. Even that he doesn't feel comfortable with it, but it's just, something that, it even can lead to an old implant that has been placed 20 years ago and that has to be re-restored, whatever the means are. So I'm aware where this question is deriving from. But what I want to say is that in my little environment, with my laboratory with 5 clinicians that I work with trustfully for many, many years, there is no implant placed without a prosthetic reference. And that can be, just in order to avoid any kind of misunderstandings, this can be based on a 2-dimensional X-ray. But there will always be the prosthetic reference on a conventional guide. It can be the most straightforward, just giving a huge occlusal hole that we reassure the occlusal screw retention, and then it gives the CEJ of the future crown margin, so that the implant depth, which is absolutely critical for exactly this question that you raised, will end up in the right depth. And that makes all the difference. That makes all the difference in the world, because that allows you to use straight components with a natural emergence profile with a proper gingiva height, elevating the cement layer away from the bone. All these important aspects, they are then incorporated into the restoration. But, that is this small microcosmos that I live in and that I sleep at night quite well, I have to say. But then I also know from many colleagues that, sometimes obviously implants are not placed and planned prosthetically driven. And then tie bases have to be the solution to everything. Obviously, they will also reach their limits. And then sometimes you have to do individual abutments. And sometimes it will remain a challenge in order to create something that more or less looks natural and is cleansable at the same time.
I like this. That's very clarifying. And the majority of the cases, do they come to you already with a pre-definition? Let's assume you have a referral base.
Yeah.
And from a prosthodontist point of view, does it come already with a pre-design or a pre-wish to you, or you go from the scan, you go top down? The reason I'm asking is this question here. I would like to, if I need your service now, I scanned it, and now I would need to create that crown. Could you walk me through your Vincent Fehmer journey through getting from point A to point B? Okay, you got the file. From now what? From now on, what?
Yeah, I mean, it's very good, and obviously, I think on a general note, before we dive into the A, B, C, D, E to get to the final, we have a more global discussion with all my customers, and they will tell me what they like, how they they want to connect two implants when they are next to each other. They prefer, if a distal extension, then it should only be a premolar. All these individual things that they might vary between clinicians. But this, having said, this happens maybe once a year or every 2 or 3 years when there has to be an adjustment, to some extent. Otherwise, it's autopilot. And then I know exactly what is their vision, what is the type of implant that they place, tissue level here, bone level there, because, that might all have an effect. But then, you sent me the data. Basically now what happens next is that if you send me just the scans without a cone beam, I will create a wax up. If there is a single tooth gap, it is usually very straightforward, and I will use the neighboring teeth as a reference, and I will create the perfect tooth, really regardless of the surrounding tissues. If there's a huge defect, I will not care. I will just deliver the final perfect tooth as a surgical template. That's it. And then the clinician will do all his rationale from there on, because only he can then literally decide it. Can he augment to some extent? Is there a chance to reach this goal? Yes and no. And then he will place the implant accordingly.
So you will send a virtual file to him first? I
will send him immediately the final surgical guide. Clear. That is the straightforward, based on only 2-dimensional X-rays, no 3D planning. However, if we go to a 3-dimensional planning with the aim of guided surgery, which is maybe 50% of then the cases, 50% is just a conventional, straightforward surgical guide. For the guided implant placement, I will upload all of those things into whatever software we use. Can be co-diagnostics, can be others. They all function more or less the same with different AI integrations. I will go through the segmentation, I will prepare everything, and obviously I will create the wax up. In this software, if I can integrate it in there with the tools of the software, like in co-diagnostics, fantastic. If the software doesn't allow you to, then I will upload it done in another software, Exocad or 3Shape, whatever. And then it's again on the side of the clinician to then plan and place the implants virtually. And obviously then I will come back into the game and create the surgical template. Sometimes it happens that we are just not sure, avoiding a sinus lift, 2 implants, 2 premolars, distal cantilever versus a 3 or 4 unit bridge, and then, placing a third implant or a second implant in the second molar area. Just one example, basically. And then I will get this advice in written or this request in written. And the great thing is today, you just save version 1 as 2 implants in the premolars with a distal cantilever, and then I will quickly design a second version and I will do the 4-unit bridge, for example. And then the clinician, again, can perfectly understand what happens if he chooses which of the treatment options. And this is phenomenal to me because, first of all, this is timely disconnected. I know exactly what I have to do. I can do it whenever I have time. I then push the ball back in your field. You plan the implants. You give me the thumbs up. I create a surgical guide, send it back to you, and you then go on to place the implants. Take an optical impression maybe on the day of implant placement. If there's primary stability, fantastic. I can already work with the data to either create a provisional or in most of the cases, especially in the posterior area, to then already come up with the final zirconia-based crown on a tie base, obviously.
And let's assume I already have my implant in position. I just need the restoration, because now I understood where you came from, because I was asking directly about the restoration, but then you were even one step behind as how it should be properly, right? Having that proper discussion even before the surgery. Yeah. Now let's fast forward. This implant is already osseointegrated. I did the optical scanning. I forwarded to you.
Yeah.
What will be your next steps?
My next steps are completely by autopilot. I know exactly by a mutual understanding what type of abutment are preferred, what type of gingiva heights are preferred by this clinician. And according to this, I will always use the longest possible abutment height. This is always the first step. I mean, when you start the case, you literally have to pick the abutment.
Not the gingival part, the longest upper part.
The longest upper part.
Right.
When it comes to the gingival part, obviously always the further away from the bone, from the implant shoulder, the better it is, but it cannot interfere, obviously, with the clinical scenario. So at one point, you have to create a transition zone and you have to create the emergence profile. It has to be not round in a cross-sectional terms, but it has to be 3-dimensional tooth shaped.
Right.
So there is, to some extent, then the limit. And then I will, once this has been selected, then I will digitally design the crown according to the occlusal scheme that, again, is mutually agreed on, but not for this individual patient, but again, once per year, something that, this customer likes, the contacts in that way, proximal contacts in that shape and form, all these kind of little details that still they play a crucial role to how you like to integrate and deliver your restorations. And then the whole thing will be processed, created, milled, sintered, stained, glazed, veneered, whatever it takes, depending anterior, posterior, assembled, sent back to the clinician. Hopefully, the patient will be better off with a great-looking crown.
Do you send already back to the clinician pre-cemented, or you give some buffer for adjustment prior to cementing?
No, obviously there is restorations and restorations. Let's imagine we are doing a super complex anterior 6-unit restoration. You don't assume that this is going to land on day one. So you could just pre-cement it with some temp bond or fast glue, whatever you want to use. That is easier to disassemble. But on a day-to-day routine, everything is finalized. And best case scenario, everything works well. The bridge integrates well, the crowns integrate well, occlusal adjustments, they might be necessary, but clinicians are perfectly able to do so, polish them up, deliver the case, and that's it. And luckily, knock on wood, that works for quite a bit. And then obviously, then some restorations are lacking a contact point, color is off, shape is not ideal, all the things that we are not machines. I would love to be one to some extent, on my efficiency terms, but I have a good day and a bad day, and this reflects then again also on the way that I'm mastering each restoration better or worse.
Vincent, for clinicians that are working with Restorative Solutions chair side and they're listening to us, or even colleagues, master dental technicians, do you have any preference on how you do your cementation protocol, or this is standardized?
Yeah, obviously there is a huge load of work and it was a huge amount of fun also, again, with Irena and Joao and Felix Burkhardt at the time to go through this kind of procedures. What is the best cement protocol? What is the best surface treatment, air abrasion versus no air abrasion? In the beginning, tie bases were categorized as stock abutments, and you were not allowed to air abrade a stock abutment. So it was an issue. So, if you wanted to have, Straumann being okay with you interfering with the components, we had to also tell Straumann, look, we have to sandblast those machine surfaces. Otherwise, we will not get the proper bond strength that we need, and we might run into debondings. So obviously, a few years passed on, and today we are looking into completely different surfaces, and we are on another level. We don't have to air abrade them anymore. We just have to apply a proper bond and silent system, and also for aesthetic reasons, this gives a huge benefit. But making a long story short, if you also asked for the focus on chairside dentistry, and there the big problem is that you have this implant solution blanks. When we especially think of the CEREC systems, and then you have the Variobase XC, for example, which is Variobase for CEREC,
right?
That then works very well in that kind of closed workflow to create a premolar or a molar crown, or even an anterior restoration, but obviously then chairside comes to its limits with the aesthetic integration. So that is a fantastic solution. It offers really a benefit to the customer, the patient, because he can have his crown in a day. Obviously, there is no lab in the middle. That also reduces the cost to some extent. But then the problem is that all the developments into more modern, scalable tie bases, more concave emergence profiles, different gingival heights, all of them, they are not to be applied in this kind of closed workflows, because it always has to go back to this, I don't want to say old, but in a way old geometry, which is the CEREC connection with this one anti-rotation feature, which is really limiting the potential of the tie base and has nothing to do with the Variobase that we use today. So this works well for maybe premolar, molar restorations to some extent, but we want to utilize the modern geometries of those components. And we can only utilize them with a proper 5-axis milling machine. And you cannot work with these prefabricated blanks with a hole, even though it might be very convenient, but it just doesn't work.
Yeah, I see exactly what you're saying. And this extension, for example, on the Straumann side with the new Variobase family,
yes,
the Variobase XC with higher cutting possibilities to customize surface treatment already from the factory. It was quite a relief. Huh?
Fantastic. You could say that the Variobase, the first line on crowns, on single crowns, already performed and was a huge upgrade, performed very well. But then there was this clear kind of next logic step, which just make it scalable, make it more concave, following the latest literature and research. But beyond that point, also doing this kind of surface treatment to basically not having to have the dental technicians air abrade the surface is another great advantage. But the biggest game changer here is multiple unit restorations, because there the shift from Variobase to Variobase XC is tremendous. This is like coming from, I don't know where to start, the Middle Ages, medieval times, and now going into a state of the art of dentistry, where we are, because the step is huge, basically. While the step from the Variobase to the Variobase XC is still huge, but is not this huge jump anymore.
Yes. We are, in fact, I see with very good eyes, we're living a very fortunate moment with our Variobase family.
Absolute.
Big kudos to the research, development, and innovation team at Straumann for such an achievement, facilitating everybody's life.
Yep.
Vincent, I would like to shift gears a little bit. We discussed about this topic that is called, it's not what we think, it's what we know.
Yeah.
And I asked you ahead of time if you have, or if you could highlight one article that for you as a professional, even on a personal level, that opened your eyes to a way of seeing or doing your work, or even shifted to a different direction. And you highlighted this one paper which Irina Seiler authored, and you also co-authored, together with many great colleagues, and it's called Fracture Strength of Zirconia Implant Abutments on Narrow Diameter Implants with Internal and External Implant Abutment Connection, a study on titanium resin-based concept.
Sorry for the long title that I made you go through, but that's how it works.
Nothing personal.
No.
But walk us through, because I really like how when guests come and they say, this was really meaningful to me, professionally and personally. Why was it for you?
Yeah, you see that this manuscript, even though it was only published in 2018, is basically the first manuscript or one of the first manuscripts focusing on modern tie bases. Yes, it is on narrow diameter implants that just pushes the envelope further, but I think still it doesn't matter, because what it shows is that we have been, or Irena has been doing a lot of research on full zirconia abutments, and they obviously have a huge aesthetic benefit, and they are also, I mean, the Cares abutments from Straumann with the CrossFit connection, they really performed spectacularly well. But then also we saw quite some failures associated to them, but they had all these aesthetic benefits. And then obviously the gold standard at the time for us was the Cares titanium abutment. So an individually shaped titanium abutment manufactured from the implant manufacturer. So original. And that would imply then a cemented restoration on top. This could be even cemented extra early in the laboratory and then still be occlusally screw retained. But obviously you see that first you have to have Straumann produce an individual component for you. It has to be sent. It is more expensive to produce. And then where was the balance? When to apply the full zirconia abutments, when to apply the full titanium abutments. And obviously this was all digital manufactured based on digital data, but it was always a split file. So you had to have two components manufactured. One you could do yourself. The other one was manufactured by Straumann. And then, we could assemble the final crown for the patient. And then this is the interesting part, why this study changed the way that we perceive things and how we work. We integrated the tie base as one of the control groups. So this was the first study then the tie base was part of. And the great thing is that we aged those components for 5 years and then we fractured them. And what you saw is that obviously all the zirconia abutments, they would literally fracture, like you envision something to fracture. It just breaks through typically in the internal connection. But then the gold standard, like a metal abutment, you see this kind of fatigue influence, and then at one point there's a bending, a mechanical movement, and normally at some point the screw head lets go. But there's like no fracture. It's just a bending. It's just a deformation. And then you saw our control group, which led to this combination of a tie base with an abutment to the exactly same failure behavior as the gold standard, which was the titanium base abutment, the individual titanium abutment. So that led to us understanding that, hey, the tie base, not only that it's very efficient in the workflow, it is very precise in the way that we can engage with it. It is also performing just like our gold standard. And that is what we were looking for. Right. We don't have to be better than the gold standard. It would be nice. But at least we don't want to be worse than it.
You don't want to lower the bar just to be efficient.
So we could move and merge those two worlds. On the one hand side, being efficient, being cost efficient, effective, and still being super stable. And that is what this study showed. And ever since we have published this study, we followed up with multiple other studies, then looking into surface treatments, looking into different heights, looking into different cement systems to make sure that those restorations then not only are cemented there, but they also stay cemented and different restorative materials. I mean, the whole thing that then followed up on it.
I like this very much because this gave you a foundational trust to the component itself. And from this moment on, the quest was what would be the right material to be on top.
Exactly.
That's your research line now?
Yes, basically. So we went on and on and on. And the great thing is that was something that Irena, I think, understood early on, it's not only following certain ISO norms with certain angulations and how to chew on something for how many times, but it was also to try to make those different research lines with the different and various abutments always comparable by having always the same master outer design shape, basically. So all these different research lines that stretch out now over 10, 15 years, they all follow the same basically geometry of a final restoration. So you can more or less compare all of them among each other. And now going into the different restorative materials that we are focusing in today, again, we can compare them to the initial studies, which just, gives more fun and a better understanding for what you can do. And I don't want to leave this podcast without mentioning that to all of you that you're in love with individual abutments, CAD/CAM fabricated individual abutments, this is always and will always be the gold standard. Nothing will ever be better than this. For a patient-created components, that's the best. But in terms of efficiency, in terms of the financial aspects, the TiBase seems to be the best kind of balance between all the worlds.
That you can combine,
Yes.
put it right in the middle.
Exactly.
It suits.
Yeah.
I love it. Vincent, building upon this conversation that you've been working on evidence and research based to put the foundation of your thoughts and directions you're going, you've come to this moment, but it was not always that way. First, your knowledge base and the technology,
Yeah.
right? And we have this section called Experience Taught Me This. Can you remember of a situation in which you could think of I wish I knew then what I know now, or I wish I had then what I have now, I would have approached in a different way. Is that a situation you can remember?
Yeah, you see that, when I started my profession, or when I started, everything was completely analog. So that might, I'm 45 now, but still, it's like I'm in this profession now 25 years. So it's already quite some years on my backpack. And obviously, I would have loved to know then what happens for many reasons.
We only could.
Yes, but we will never get to this point. But I have to say that I'm extremely happy that I learned it the analog way. I learned morphology the analog way. I learned to wax up. I learned to do all those things because in this digital environment, a lot of it is supported to some extent today, even by AI or by algorithms that help you align morphologies and snap morphologies to something that has been preset. But I still understand the fundamentals. I still understand why a cuspid has to be where it has to be and why you need freedom in space and movement at certain other areas. So for these things, I'm happy. I would have loved to know what happens, where we are today. For me, a lot of things in our profession are still common sense. When I looked into the first abutments for multiple unit restorations, not on multi-unit, it's always a bit difficult to differentiate if you don't have a picture in the background. But if you think of a 3-unit bridge, you would go directly to the implant level. And then I saw for many, many years components that were conical, because it just made the workflow more easy. So you were non-engaging and conical on top. And then for me, it was absolutely clear that this doesn't make any sense. I could use the best surface pretreatment on both sides, the zirconia as a bridge, as well as the titanium as a base. But there will be lateral forces that eventually will lead to a debonding. This is just one of the examples. So if you look at it with common sense, you will understand this is not going to work. So what we did is we used abutments for crowns in order to have cylindrical components that would give more resistance, more surface, more everything. So did I do any of these fundamental mistakes? I went through all the mistakes. I went through all the failures. If you want to pinpoint one, I could basically go back to the starting point of zirconia when we just related zirconia to a framework material. And we did beautiful frameworks out of zirconia, very precise, beautiful to some extent, but then we veneered them completely. especially on implant-borne restorations for full arches, this was a very, very costly mistake. Luckily for me, I was not self-employed at this point, so the financial impact was on the one hand side on my previous bosses, and then today it went back to the university. So seeing all these failures, I would have loved to have the vision for utilizing it immediately in a monolithic shape. But also I have to say that the milling capabilities, the design features, they were all not there yet to create a morphology, both occlusal and buccal approximately that would actually have looked like a tooth. So it was just a matter of time, and certain things you just have to learn that they don't work, and that's it.
You mentioned the framework, and that's a very how would I put this together? That's a very dangerous setup, I would say. And in the majority of the cases, the question I just asked you, for example, if it's a crown, and years later, you can always start over and you do another one. But in a full arch context, it can be quite cumbersome and
expensive, I have to say.
And expensive. But at least there's not one situation that you could remember that the restorative choice affected the whole biology there.
Yeah.
None.
Honestly, obviously, yes, because you see the first generations of tie bases, again, certain ones that they would allow the system only to produce, let's say, sorry, it's technical, but it's, let's say, a gingiva height 1.
Right.
And some of them would then create very, very steep angles. So, like having a 60-degree abutment angle within 1 millimeter gingiva height. So that was literally it's like close to 90 degrees. So you can imagine we called them the sombrero heads. And they really had a severe biologic negative impact that led to bone loss associated to those kind of clearly tie base. So it was just the tie base one. The implant was perfectly fine and before we then delivered those final restoration. And then you had this absolutely unphysiological abutment design that led to biologic impacts. And that is certainly something that, that I wish that we went not through this phase.
Jump started directly to today.
Exactly. So here we are. We learned a lot. But, you also have to keep in mind that this comes from a time where we would create individual abutments with a lot of contour, supporting tissue. So we were very convex, really filling the space, thereby thinking that we would support the surrounding tissues and prevent them from basically maturation or disappearing. So we learned a lot, all of us, in terms of a dental community. And to know today we know better. And luckily today also the industry provider listened and then came up with components that enable us to work properly.
Vincent, before we start heading towards the end of our conversation, we've come long ways, right? What do you imagine we could go next that will make your life even easier? Let's put it that way. And that you don't have this conversation 10 years from now and you say, I hope I knew in 2025 what I know now in 2035, which you're missing today.
I mean, I would really love to tell you something because it obviously also would make me look good or sound good. But I know that I don't know. I really understand one thing in my life, that I'm surprised by what comes around the corner. We are privileged and happy to see certain degrees of developments by industry partners that we trustfully collaborate for many, many years, that we have a certain sneak and peek into new developments that, maybe before they come to the market, we can already work with them or test them or at least give certain feedbacks. That is fantastic. But this is like something that we're looking into the future of 1 or 2 years. I know there will be more of printing. There will be more of printing, even high-strength ceramic materials. This is, to some extent, logic. But I assume that in 5 or 10 years from now, we will again talk about completely different things that, again, I don't dare to imagine. And also, I don't have a proper imagination. So I just can't say a proper answer to that.
And that's a lovely answer already, because look, that makes us healthcare providers. What you're saying today, it means that you feel completely comfortable that the technologies that we have today at our hand, we feel good working with. We feel good that patients are in the center of everything we're doing safely. And what else? What else can we expect? Good days, huh?
Yeah. I mean, definitely. I mean, let's assume that everything that comes beyond today is going to improve the workflow, either in terms of accessibility, efficiency, price, effectiveness. All of these things should be in favor of something. I don't think we will step back in time. So it ends up being good for the patient, ends up being good for the communication, for efficiency. I mean, all these things, I assume, will be to some point beneficial. But the type of healthcare that we are able to provide today, utilizing the new technologies with, let's say, the Variobase in the center. One could pick other centers, it doesn't matter. But it is I think, a great period, a great time, and we deliver fantastic rehabilitations to our patients.
Vincent, this for me was a masterclass. I wish you could have a whole day here with you. I learned tons. And to everybody who's watching us today, where can they find you about your educational offerings, the journals you're involved with, how they can start going?
Yeah, I mean, first of all, the journals are a lot of fun, together with Quintessence, the International Journal of Aesthetic Dentistry, or the QDT. Have a look at it. We also published a full book on fixed rehabilitations that can also be interesting for you. You can find us, the entire team, at the University of Geneva on the homepage, all associated with our names and email addresses, so you can always reach out. For the ones, that even imagine to travel to Switzerland, we also have tons of courses that we offer. But even if there is no course and you just want to go to the French Alps to ski or to the Swiss Alps, I mean, just reach out to us, and there is always open doors. We show you around. We have constantly guests, so there is always space for one more. And obviously, we are always on social media. So if you want to reach out to us, I'm sure you will find your means and ways to connect to us. And I can only invite you all to Geneva. And if you're interested in what we have just discussed, listen to more from us, or also share your thoughts. I mean, there is always new ideas that also, I mean, we are constantly surprised what people are doing, and we try to learn from everything that you have to teach us.
Vincent, it was a pleasure. Thank you very much for all this.
My pleasure. Thank you so much for having me.
And to all of you watching us today, we're going to leave the links, how to access his social media accounts, have access to the links he mentioned at the University of Geneva, and also the journals Vincent Fehmer is involved. If this episode was relevant to you, make sure you comment. We need that comment to know which direction we go, if we're doing the right things or where we can improve. Until the next episode,